abnormal uterine bleeding. So diagnosis of in the diagnosis of AUB, history taking is very very important, and general in the we have to do general and physical examination, gynecological examination, and if you are asked how to manage, how will you manage AUB means you have to start from investigations. Then you have to discuss about treatment. In the exams, we have seen that many students, when asked about management of any condition, they will start from the treatment itself. But management includes both investigations and treatment. And also, you must be able to tell whether you want to admit the patient and treat it as inpatient or outpatient. Also, you must be able to tell. So coming to history taking, in the history, age is very important. So depending upon the age of the patient, cause of cause of AUB varies, causes varies. Then the investigations what we do and also the treatment options also will be different. If the age of the patient is around puberty, it is pubertal menorrhagia. The common causes are anovulation, and then you should think of clotting disorders, Van Willebrand's disease, then idiopathic thrombocytic penic purpura, because in 30%, 20%, 20 to 30% of the cases of puberty menorrhagia, it is due to coagulation disorders. Then if it comes to reproductive age group, the causes are mainly polyps, fibroids, and adenomyosis, like adenomyosis, PID, endometritis. The etiology differs. When it comes to perimenopausal age group, we have to do DNC to exclude malignancy, because endometrial pathology is mandatory. And then in the treatment options also, you can give the option of hysterectomy. Whereas for postmenopausal bleeding, you have to exclude malignancy. So the etiology varies depending upon the age of the patient. So age is very, very important factor by taking history in case of AUB. Then in the menstrual history, you can write previous menstrual history and present menstrual history. In the present menstrual history, you have to elaborate the complaint in detail, since how long she is having that menstrual disorder and how it has progressed till date. So if she says excessive bleeding, don't use other terms like over bleeding, extra bleeding, like that. Don't use the terms. You write heavy menstrual bleeding if she says the amount is more. And if she says that the bleeding is for prolonged periods, like 8 days, 9 days, 10 days, she is having bleeding, means you write prolonged bleeding. So heavy, heavy or excessive bleeding for prolonged periods, that should be the terminology. Then you can write for 10 days she is bleeding, for every 35 days she gets cycle. Then you write it as 10 to 11 days by 35 days. Cycles are regular. And then volume of, regarding volume of bleeding, you ask about how many pads she changes and any history of causes of clots and the size of the clots. Then any history of flooding or flushing is there or not. So you have to mention these things. Then how the symptoms have evolved till now. That is, previously she used to have bleeding for 7 days. Now she is having continuous bleeding since 1 month. Like that, you must be able to tell. Then the treatment history she has taken is compulsory. So she must have consulted some doctor whenever she had this heavy menstrual bleeding, and what is the treatment she has taken and what are the drugs. uh, she must You must elicit that history. So what is important is she might have taken some hormonal therapy like progesterone, she might have received. So if you ask, if the patient tells that she has taken tablets regularly for 28 days or 30 days, that indicates that she must have taken some hormonal therapy. Then any DNC she underwent or ultrasound she underwent, what is the treatment she has received, you must take the detailed history. Then previous menstrual history also you have to take. In the previous menstrual history, what is the regularity, frequency, duration of bleeding, and volume of blood loss you have to ask, and associated with dysmenorrhea or not, you have to take. Anovulatory cycles are not associated with dysmenorrhea. Only ovulatory cycles will be associated with dysmenorrhea. Then any history of postcoital bleeding is there or not, you have to ask. Then whether it is when dysmenorrhea is present, whether it is spasmodic or congestive, you should tell. So what is dysmenorrhea? Painful menstruation is dysmenorrhea. It is of three types: spasmodic dysmenorrhea, congestive dysmenorrhea, and what is the third one? What is the third one? Somebody please answer, because whether you are hearing or not, I don't know. So tomorrow, all of you please write about dysmenorrhea and send it in WhatsApp. So any associate, whether it is associated with dyspareunia or not, that is pain during coital activities present or not, you have to write. In the obstetric history, if she had 3 children, para 3, live 3, any abortions A2, then whether she, what is the type of deliveries, any complications during the delivery, and what is the age of the last child, and whether tubectomized or not. Then when she is tubectomized, whether it is postpartum sterilization or interval sterilization. And then sometimes the patient might have undergone MTP, then simultaneously they might have done tubectomy. So MTP plus tubectomy, like that you have to write, because we heard that post ligation syndrome is one of the cause of AUB. Then any associated with vaginal discharge. If the patient gives history of vaginal discharge, urinary symptoms, pain in the lower abdomen, then some mass in the abdomen, what is the things that comes to your mind? It may be chronic pelvic inflammatory disease, chronic PAD with TO masses, any history of recent abortion, delivery, and any history of ectopic pregnancy. Any woman in the reproductive age group uh, complaints of bleeding or any abdominal mass, you should first rule out pregnancy related complications. Then any recent abortion, delivery means immediate postpartum and post-abortal period, because of some endometritis, they will have excessive bleeding. Then any history of iatrogenic causes of AUB, like any history of IUCD insertion, uses of oral contraceptive pills irregularly, then any hormone therapy, like progesterones might have been taken, and if the dose is not sufficient, they will have breakthrough bleeding. And any drugs, like any history of uses of any anticoagulants, phenothiazines, then tricyclic antidepressants, you have to ask. Then important points in history taking is menstrual history, you have to split it like previous menstrual history and present menstrual history. Then associated with pain abdomen, it is very important, because in a woman in about 35 years old complaining of heavy menstrual bleeding and prolonged bleeding associated with pain abdomen, what is the differential diagnosis, they will ask. So what could be the first cause? It will maybe fibroid uterus, then adenomyosis, pelvic inflammatory disease, endometriosis, uh, or polyps. So how will you differentiate? So by clinical examination and by investigations, you will come to your provisional diagnosis. Then associated urinary symptoms, you have to ask bowel symptoms, any history of uses of medications like non-steroidal anti-inflammatory drugs for prolonged periods, anticoagulants, any herbal drugs for weight loss nowadays people are using, and they're coming with menorrhagic cycles. Then any phenothiazines, tricyclic antidepressants, morphine, you have to ask. Then in which conditions, this is question for you all, in which conditions both heavy menstrual bleeding and dysmenorrhea are present? Please answer. Yes, in which condition both are present? Okay, very good. You can answer boldly, no? Huh? Why you are keeping answers privately? Huh? As a student, you have to learn and you have to, that is your purpose. Why you feel hesitated to answer in public? Huh? Okay, the answer is all. So this is important because if you get a case with both excessive bleeding and pain of dysmenorrhea, in the differential diagnosis, you have to tell all these conditions. So among ovulatory and anovulatory cycles, which is associated with dysmenorrhea? Whether it is ovulatory cycles are associated with dysmenorrhea or anovulatory cycles, already I have answered. It is ovulatory. But why? What is the reason for ovulatory cycles being associated with dysmenorrhea? You please refer and tell me tomorrow. So in the menstrual history, you write these things in order because you might be knowing from fourth semester onwards, but I am telling for the purpose of all people, it should be written in order. First AZ menarche, the girl attains menarche and she gets menstrual cycles, and LMP you should mention number of children and what is the type of deliveries, then last childbirth, and then she will be tubectomized. So in order you write, because we see students writing menstrual history first, then number of children, then marital life in the last they will be writing age at menarche, like that haphazardly they will write. But you can remember it is in chronological order, sequence of events that occur in life of a woman, you can write in sequence. So in the past history, any similar complaints in the past, she might have suffered with the similar complaints and she might have taken medical treatment or sometimes surgical treatment, like DNC she might have done, she might have undergone, or some um, balloon balloon thermo balloon therapy, or Mirena she might have uh, be using. So what is the treatment she has taken? You have to elicit the history. Then any previous history of known case of hypertension, diabetes, hypothyroidism, epilepsy, and tuberculosis is very, very important. If the patient is suffering with hypertension, it might be the general cause for menorrhagia. So if she is obese, she is a patient of hypertension and diabetes, she might be, this may be corpus cancer syndrome or metabolic X syndrome or syndrome X. Then hypothyroidism is one of the endocrinological cause for AUB. If she is an epileptic and using anti-epileptic drugs, these are the drugs that may be causing menorrhagia. If she is a case of tuberculosis in the initial stages causes menorrhagia, and because of tuberculosis endometritis, then adhesions, she may go into Asherman syndrome. So any history of blood transfusions she has received is very, very important, and family history of blood dyscrasias, particularly in case of puberty menorrhagia. So what is corpus cancer syndrome? It is association of hypertension, diabetes, and carcinoma of the endometrium. Because of hyperestrogenism, they are more prone for endometrial hyperplasia and endometrial cancers. So metabolic syndrome and syndrome X is same. So in the general and physical examination, you have to see for how will you write general and physical examination. You start from conscious, coherent, well oriented, that we will be writing, and then built and nourishment. So moderately built, moderately nourished, anemic, anemia, jaundice, then cyanosis, clubbing, chylonychia, edema of the feet, and generalized lymphadenopathy. You write in order, from top to bottom, you write in order. Then height, weight, BMI, you have to mention in the general physical examination. Then you have to write about the examination of the neck for any thyroid swellings, examination of the breast, then gait and spine and gait. So height, weight, BMI, examination of the neck for any thyroid swellings, breast examination, spine and gait must be mentioned in general and physical examination. Then comes the vital data. You know very well. Then systemic examination, other systems examination, cardiovascular system, respiratory system. Briefly, you mentioned S1, S2 had no abnormality detected. Respiratory system, bilateral air entry normal. Then comes the obstetric, comes the gynecological examination. In the per abdomen, you have to write inspection, palpation, percussion, and auscultation. In obstetrics case sheet writing, only inspection, palpation, and auscultation. No percussion in obstetric case sheet writing. Whereas in gynec, you have to write it under the 4 headings, and then you are not allowed to do perspeculum and bimanual examination. But we will give the findings to you. Okay. But you must be able to tell how do you do perspeculum examination and bimanual examination, and what are the how will you correlate with your findings. So in some cases, per rectal examination may be needed, like malignancies, or if she is unmarried presenting with any abdominal tumor, you have to do per rectal examination. So coming to investigations, women in reproductive age group means you have to exclude pregnancy by UPT. So all investigations must be relevant to your case, but not that all investigations must be done in all. It must be only relevant investigations must be done. And in complete blood picture, CBP is very important. In the CBP, you will know HB percentage, whether woman is anemic or not, you will know, and severity of anemia you can know. Then if there is lymphocytosis, maybe tuberculosis or chronic disease is there. There may be leukocytosis in acute infections, and then if she platelet count you can see, then ESR raised or not you can know. Then you have to do bleeding time, clotting time, and coagulation profile, particularly in case of puberty menorrhagia. Then complete urine examination, urine for culture and sensitivity, if there any urinary symptoms are there. Blood grouping and RH typing. This is important for she may need blood transfusions, so you will do that. Then thyroid profile to exclude hypothyroidism. If she is perimenopausal age group, you have to do FBS, PLBS to exclude diabetes mellitus. Then LFT, RFT will do. Then ultrasound pelvis. Preferably transvaginal sonogram is preferable because of high pelvic tumors can be better diagnosed by transvaginal sonogram. Then depending upon the need, saline sonosalpingography, particularly to differentiate between endometrial hyperplasia and polyps. This will help. Then diagnostic hysteroscopy is the gold standard for postmenopausal bleeding. Okay. So under visualization, you will take the biopsy from the suspected sites. Then endometrial sampling for histopathological examination, either by DNC or endometrial aspiration with Pipellis aspirator. Then diagnostic laparoscopy and pelvic angiography depending upon the case. Pelvic angiography is for diagnosis of AVM, arteriovenous malformations. So this AVM comes under which category of palm coins classification? AVM comes under which category of palm coins classification? N, very good. N means not yet classified. Not yet defined, not the, it is not yet classified. So this is Pipellis endometrial aspirator. So as an outpatient procedure we can do, this is introduced into the uterine cavity and we aspirate it and you send it for histopathological examination, they have seen that this specimen with Pippellis endometrial aspirator is as good as DNC specimen. So coming to treatment. So depending on, based on the, with the help of these investigations, you will come to the cause of AUB, and then you have to, you'll go to treatment of AUB. If it is an acute AUB means a woman presenting with an acute episode of bleeding which requires some intervention. Then that is, she is having heavy bleeding. Sometimes the woman may be in shock. Then you have to first to do resuscitation. Don't send the patient to get ultrasound, get done and come. If the patient is in shock or she is anemic, then you have to first resuscitate the patient, then correction of anemia with packed cell transfusions, then control of bleeding. Simultaneously, you have to do these things. Control of bleeding. What are the drugs used for managing bleeding episode? We give injection tranexamic acid. So injections are available. 10 milligrams per kg body weight can be repeated 8 hourly. Then we can give progesterone tablets, that is MPDA, medroxyprogesterone acetate tablet, available as 10 milligram tablets. For control of bleeding, we give 3 times a day, TAD, 10 milligrams given 3 times daily till the bleeding stops. So bleeding will be stopped in 2 to 3 days with the TAD dose. Then slowly you have to taper the dose. Otherwise, if you stop abruptly, she will get withdrawal bleeding. So 10 milligrams TAD given for 3 days, then 10 milligrams BD 2 times daily for 3 more days, then 10 milligrams OD for 16 to 25 days. So that after stoppage of that tablet, she will get the regular cycles. Then if the bleeding is not controlled even with progesterone, then you can go for other progesterones are also available. That is Regestrone is better drug for control of bleeding when compared to medroxyprogesterone acetate. You can remember Regestrone tablet, what we commonly use in the gynec OP. Combined OC pills also can be used to control bleeding. In our government hospital, we give Mala D to take the tablet 2 times a day or 3 times a day for control of bleeding. Then taper the dose, daily 1 tablet for 1 month she can take. Then conjugated, they have prescribed conjugated equine estrogen injections. That's a injection Premarin 0.025 milligrams IV every 4th hourly, followed by oral tablet Premarin 2.5 milligrams 6th hourly. So out of all these, this estrogen is most effective in control of bleeding, but we have not seen its uses because we have not used these things. For control of bleeding, acute episode of bleeding, we can use tranexamic acid, progesterones. Then even if it is not controlled, you can use combined oral contraceptive pills. Sometimes in some patients, they will be having bleeding, and in the ultrasound, there will be atrophic endometrium. That is, endometrium will be very thin. Then if atrophic endometrium is there, that means there is no estrogen. So you have to supplement the estrogen, otherwise the bleeding will not be controlled with progesterone alone. So coming to treatment of, so acute episode of bleeding, you have controlled the bleeding, then you have to evaluate the case. That is, you have to do investigations to know the cause of bleeding. Then after investigations, you will come to conclusion what is the cause for that, and then you have to treat the cause so that she will not have the next episodes. So some question from liver function test and renal function test is, in liver diseases there will be decrease in the coagulation factors, and also renal function test, the patient may be suffering with some renal problem that may be the cause for anemia, and whenever you are doing any procedure, surgical procedures, we have to do this liver function test and renal function test. Okay. So is it clear? In an acute episode of bleeding, first resuscitate, then correct anemia, control the bleeding, then evaluate for identification of the cause, then you treat that cause. So then she won't have any recurrent bleeding. Otherwise, you have controlled the bleeding, but you left it like that. Again, she will come with another episode of bleeding in shock like that. So coming to treatment of chronic AUB. Chronic AUB means for more than preceding 6 months, uh, she is having the symptoms, that is altered menstrual bleeding in periodicity, chronicity, then flow or duration. You call it as chronic AUB. Uh, our management depends, should be aimed at, first is control of bleeding, then correction of anemia, prevention of recurrence of bleeding, identification of the cause, and treat the cause. So whenever you are asked in exams, how will you treat fibroid uterus, that is AUBL, how will you treat? You don't say directly say hysterectomy or myomectomy. First how will you control the bleeding, then correct the anemia, like that you proceed. So coming to management of AUB, it can be divided into under the headings of medical management, conservative surgical management, and medical management. In the surgical management is again conservative surgeries and radical surgery. Radical is hysterectomy, you remove the organ, whereas medical management will be divided into non-hormonal and hormonal therapy. The conservative surgeries, MIS, that is minimal invasive surgeries. DNC is also DNC, then uterine artery embolization and myomectomy. You can see in the non-hormonal therapy, prostaglandin synthetase inhibitors, that is non-steroidal anti-inflammatory drugs. Then antifibrinolytics, example is tranexamic acid. Then we use ethamsilate, it is capillary fragility stabilizer. So these are the non-hormonal drugs, and also diosmin we use. Hormonal therapy we use progesterone. You please answer this question, because in the hormonal therapy for AUB, what is the first line of drug you use? That is the question you usually get. That is progesterogens. You write progesterogens. Okay. Then combined oral contraceptive pills. Then Mirena you can use, and in some cases gonadotropin releasing hormone agonist and antagonist. This Danazol we are not using nowadays. So in the non-hormonal treatment of AUB, only we use four types of drugs. For each drug, you must be able to tell what is the mechanism of action, and what is the dosage, and what is the percentage of control of blood loss, and side effects, and any important complications you must be able to tell, and whether it is effective in which case it is effective, whether it is effective in ovulatory AUB or anovulatory AUB, AUBE, whether it is effective or not, you must be able to tell. So you prepare notes under these headings. So in the non-hormonal therapy, we use antifibrinolytics, that is tranexamic acid, and non-steroidal anti-inflammatory drugs, mefenamic acid, flufenamic acid, and ibuprofen. Out of this, we commonly use mefenamic acid, that is Meftol Spas. Combination of tranexamic acid and mefenamic acid is available. Tranexa MF, like that. Any patient comes with bleeding and in pelvic examination, till she gets investigations to control bleeding, we prescribe this tablet, Tranexa MF, like that. Then ethamsilate, it is capillary fragility stabilizer. So ethamsilate is very weak drug to control the bleeding, but combination of tranexamic acid and ethamsilate is also available. And another one is diosmin. So tranexamic acid is a antifibrinolytic agent. You please remember this word. Tranexamic acid is an antifibrinolytic agent. It is a competitive inhibitor of plasminogen activator. So it inhibits the lysis of the clot already formed. And it is useful for treatment of menorrhagia and it reduces the breakdown of fibrin, that is preformed clot in the spiral endometrium arterioles, and thereby reduces the menstrual blood loss. The reduction in the menstrual blood loss is around 40 to 60%. So whenever you are using tranexamic acid, you can give assurance to the patient that the reduction in the blood loss is around 40 to 60%. And it is effective in ovulatory AUB, but it however does not reduce dysmenorrhea, and it is not a contraceptive, and it cannot regularize the cycles. Because if you are using combined OC pills, a patient suffering with menorrhea, that is AUB, and she wants and contraceptives, then you can use OC pills like that. This tranexamic acid cannot reduce dysmenorrhea, not a contraceptive, and cannot regulate the cycles. So it is cost effective when compared to other non-steroidal anti-inflammatory drugs, and when compared to Mirena. So dosage is available as 500 milligrams tablets. The patient can take 2 tablets 3 to 4 times daily from the when she will be taking this tablet. This has to be taken from the onset of bleeding up to 4 days, because these progesterone tablets, if they must be taken for in cycles, we start that tablet on 5th day. Our OC pills means we start the tablet on 1st day. Like that, when this tablet has to be taken means it has to be taken during from the onset of bleeding up to 4 days. So mechanism of action is the endometrium possesses an active fibrinolytic system, and the fibrinolytic activity is higher in menorrhagia. So this tranexamic acid, as it is having anti-fibrinolytic activity, it controls the bleeding. This tranexamic acid is effective in treating menorrhagia associated with IUCD. So this IUCD, it comes under palm coin I, iatrogenic AUB. So any patient with the IUD in situ complaining of menorrhagia, you can prescribe this tranexamic acid. The side effects are mainly dose related. They are nausea, vomiting, diarrhea, dizziness, rarely transient color vision disturbances, and intracranial thrombosis. This is very important. Intracranial thrombosis is the threatening complication with tranexamic acid. So it is the tranexamic acid is the first line of drug for AUB. So in the gynec OP, usually for any case of AUB, first we prescribe tranexamic acid. Remember this one. Then dosage is 2 tablets 3 times a day for 5 days. During periods, it should not. During bleeding, she has to take. It is the drug of choice in coagulopathies because it does not act on the platelets, unlike non-steroidal anti-inflammatory drugs. So in coagulopathies, we should not use non-steroidal anti-inflammatory drugs, but you can use tranexamic acid. Then it is not advised if there is history of any thromboembolic disease, and it should not be combined with combined OC pills. So coming to NSAIDs, the mechanism of action is they reduce the prostaglandin synthesis by inhibiting the cyclooxygenase synthetase. So the cyclooxygenase synthetase, it converts arachidonic acid to prostaglandins, that is prostacyclins and thromboxane A2, which are vasodilators. So there is inhibition of synthesis of vasodilators. So vasoconstriction will dominate and bleeding will be controlled. It reduces the menstrual blood loss by 20 to 50%. So which is better, which is superior? Tranexamic acid is better, that is 40 to 60%. But tranexamic acid and danazol reduce the MBL greater, but we are not using danazol. It is less cost effective than tranexamic acid and Mirena. It does not have any contraceptive effects, and it not to be used in bleeding disorders. You please remember, in coagulopathies, we should not use non-steroidal anti-inflammatory drugs, but it relieves dysmenorrhea, unlike tranexamic acid. This mefenamic acid, it controls bleeding and also pain abdomen. So the cyclooxygenase pathway is arachidonic acid will be converted into prostaglandins. These thromboxane A2 and prostacyclins are vasodilators. So cyclooxygenase synthetase, this step is blocked. So there is decrease in the synthesis of prostaglandins. Dose is 500 milligrams tablets 3 times a day. During period she has to take. The side effects are nausea, vomiting, gastric discomfort, diarrhea, dizziness. Sometimes, very rarely, hemolytic anemia, thrombocytopenia will occur. So the degree of reduction of menstrual blood loss is not as great as it is with tranexamic acid, but relief of dysmenorrhea will be good. So these are useful. These mefenamic acid is useful in AUBE and AUBO, that is ovulatory defects and endometrial defects, dysfunction. This can be used. It is moderately effective when compared to tranexamic acid. It can be combined with tranexamic acid. So combination of tranexamic acid plus mefenamic acid is available. So NSAIDs with antiplatelet action are aspirin, naproxen and ibuprofen. So ethamsulate is a capillary fragility inhibitor. So it causes the stabilization of the blood vessels. Then dose is 500 milligrams 3 times a day. It can be combined with tranexamic acid and non-steroidal inflammatory drugs. It is not very effective when given alone. So combination, we have to combine this with along with tranexamic acid or mefenamic acid. So it maintains the capillary integrity, anti-hyaluronidase activity and